I would like to actually thank the organizers for having this talk included in the program. And also this is my disclosures, and I also would like to thank, I'll thank at the end, but the team Sam Filippo and especially Kathy Buckley actually to be a partner in this project and actually fund this project. So as just an introduction, I'm gonna start actually continue with Dr. Manzer about the inflammatory aspects of disease. So basically there are many so lysosomal disorders are due to substrate collection, due to enzyme deficiencies mainly, but then there are the downstream events which are characterized by lysosomal dysfunction. Lysosomes not only are garbage can or the trash collectors in the cell, but there's a crosstalk between multiple organelles that includes mitochondria, nucleus, and that actually leads to the degenerative events, especially in the neuronal pathways. So what happens is then the other downstream events, which are characterized mainly by inflammation, take over, and we have seen this published in MPS 3 and multiple lysosomal disorders. So inflammation and neuroinflammation plays a critical role in MPS 3, driven by macrophage and microglia activation and dysfunction. And nerve 3 inflammasome activation actually is exacerbated by the secretion of these inflammatory, pro-inflammatory molecules, mainly IL-1 beta and IL-18 levels. And this further disrupts the lysosomal other cellular events. So there is a vicious cycle that continues with the disease. So unless you break either of those, the disease will roll into itself. So the first figure here is being published for Gaucher disease. This actually depicts how the nerve 3 inflammasome is activated. And the below is our hypothesis that is the inflammasome is activated, but then it activates the other elements that is related to pyroptosis, which is the inflammatory cell death. And then the cellular that ensues, this is why we see in the brains is neurodegeneration in a very simplistic manner of use. So I am the director and the founder of LTRTC, which is exclusively actually a center for lysosomal disorders. We may be new to the MPS 3 patients, but we have extensive experience with Ambroxol hydrochloride that we have been using for some other patients. That is out of formulary, obviously. So Ambroxol has been around almost more than 3 decades, and unfortunately, it is not present in US, but it actually exists in multiple countries. That includes Japan, West Europe, and Canada. And when I was writing the investigator brochure for this protocol to the FDA, I used the data from Japanese group from early 1990s. So there are multiple forms of Ambroxol that includes tablets, solution, and also the IV form. It is mainly used as a saccharolytic agent and is a sodium channel blocker, and its main indication in adult and pediatric subjects, acute and chronic pulmonary disease. And in newborns, actually there is an IV form that is given in pregnant females for preterm labor, and also in newborns it is used in hyaline membrane disease. So how did Ambroxol came into picture as a lysosomal, as a potential therapeutic agent in lysosomal disorders? Actually, if you go back to early 2000s, it has been suggested as a molecular chaperone, which would chaperone glucocerebrosidase to the lysosome and then enhance its actual activity, and using these heat and activation studies. And first, this has been published with 2009 by my friend and colleague Gustavo Mageva, and it's proven that it is actually pH dependent, is a mixed chaperone for glucocerebrosidase. So basically, it is both activates and inhibits at the same time, but the difference between the other chaperones known and is being used in lysosomal world, it doesn't need to be washed out. So basically, you can do multiple dosing without inhibiting, but what happens in the higher doses, it starts inhibiting the enzymes. So It is metabolism is unfortunately is influenced by multiple medications, including the seizure medications that actually is a probably is a big detriment for this kind of population. So to the right side, what you have seeing is, and the other thing is Ambroxol responsiveness as a chaperone is very much patient dependent. There are some mutations for glucocerebrosidase that are known to be non-responsive to Ambroxol, which is the most common mutation. But when you see the family members, actually they may respond in a different way each. So these are the studies from the siblings. So what we mainly use Ambroxol as actually in some studies is whether the phenotype will be favorable or not, because when you can refold a protein, it means that there are other factors that can actually affect the end phenotype. Anyhow, so let's come back to MPS 3 is why it may be important, because it is proven to cross the blood-brain barrier in multiple studies. About 10% actually goes through the blood-brain barrier. And what is promising from this experiments that is done on patients with Gaucher disease, actually in the macrophages, it changes the expression profile of immune system genes. So we think that actually this is mutation agnostic, which means that it is not dependent on the chaperone properties, but it is dependent on the anti-inflammatory properties of Ambroxol. So what we did is we had some information. Obviously, we knew that it worked both in the plasmic reticulum and in the lysosomal pH to activate the enzymes, and it stabilized the lysosomes and promoted the autophagy and also enhanced lysosomal proteins like LIM2. So the question we pose whether this could be applied to the subjects or the patients with MPS. So what we did is in an IRB approved study, we collected PBMCs and in some patients the skin cells, and we looked at these properties, whether it increased the enzymes, increased autophagic activity, and then increased the lysosome fusion. So these markers that you're seeing on the right-hand side, actually this is also subtype agnostic. So it included from patients A to D, and also we saw the similar response in the normal controls. The thing is that Ambroxol is an anti-inflammatory excess effects and it's a clinic actually type irresponsive. So with the escalating doses, if you see the red staining, Ambroxol actually showed that it was improving the autophagic activity and also increasing the lysosome numbers, and that is probably is the pH, basically making the lysosomes more pH, so basically improving the lysosome function. So still this wasn't enough. So what was the real reason Ambroxol was improving all these lysosomal function? So basically we ran into as an accidentally or incidentally. So we have been using Ambroxol as a control agent in some other studies that involved pyroptosis, this inflammatory cell death, and caspase mediated cell death. So we can't use Ambroxol as a control, and to our surprise, actually Ambroxol was able to decrease the both IL-18 and IL-1 beta levels as a control, but obviously it wasn't as a control. So we questioned whether this was purely NERV3, and it wasn't. As you're seeing, one of our patients actually was NERV3, carrying a NERV3 mutation with NERV3 activation. So it wasn't only NERV3. We used chitotriosidase as a macrophage activation marker. It was also actually that is changing the immune profile of the cells. So how we can use Ambroxol, obviously by targeting neuroinflammation, substrate clearance, and autophagy pathways. In other studies that is done on patients with Parkinson's disease, it was able to reduce the alpha-synuclein actually in the animal models, and also in the patients, actually it was going through the blood-brain barrier. So we thought that as a combination therapy to address the complex pathogenic cascades involving immune activation, inflammatory cell death, Ambroxol Ambroxol could be valuable, especially in MPS 3. So we actually started, we wrote the protocol, submitted to the FDA, and then the question was what was the marker and whether this could be just a safety study since there was no data in MPS 3 patients, but they wanted to actually have us to put some efficacy studies because they were very much interested to have an Ambroxol study in US. So basically with back and forth correspondence, the GAG biomarkers obviously help track the disease, not only progression, but also, you have seen the HS as a marker for efficacy, and also incorporating neurocognitive assessment such as Vineland scales would actually indicate the progression or the lack of it. So the study would include patients with MPS 3A to D. This is agnostic to the clinical type because we are actually intending to use as an adjunct therapy at some point. And the main, actually, the point of these studies were to assess the pharmacokinetics and pharmacodynamics of the study. So to make the long story short, I wrote the trial as an 18-month study, but due to delays in getting the medication into US, what we did is we divided the study as an observational and as a therapeutic part. So for the observational, we included patients that actually had GAG increase in both their urine and also in their blood because we would like to actually assess the efficacy of the drug. So with that said, for the observational part of the study, so we enrolled 10 patients, 5 adults and 5 children. Currently, the therapeutic arm is only written for 18 and above, and you can ask why we're enrolling then children, because the ultimate aim is to go down to really early ages to use this, since there is data in newborns actually with Ambroxol. So why not can we use in early treating the patients? However, with the lack of data in especially MPS 3, FDA wanted us just to dose the adults first and assess the pharmacodynamics and the kinetics and safety before we moved to the pediatric patients. So we enrolled 5 adults and 5 children. This is all MPS subtypes, including A, B, C, and actually we have D 0 patients. So we have C also 0 patients, mainly A and B. The mean age for the adults was about 26.8 years, and 4 males and 1 female, and pediatric is about 10.4 years, 1 to 4 male to female. And obviously I need to indicate that these patients are not eligible for any other therapeutic trial that is currently going on. And this is an overview of the patients that are enrolled as adults. So basically, we both had attenuated phenotypes in here. The first 2 patients, actually one of them was attending college, and also some severe phenotypes who are currently having recurrent seizures and wheelchair bound. So basically, the treatment arm of the protocol is a single center investigator-initiated pilot study. It is going to get conducted at Fairfax, Virginia, with a duration of 52 weeks of treatment and 4 weeks of therapy. There are 3 months with dose escalation from 3 milligram per kilogram to 9 milligram per kilogram with a max of 450 milligrams per dose 3 times a day. So the issue with that we didn't go higher on this, which we could have done, but we were only able to get the 30 milligram of dose of Ambroxol. So each actually dosing will involve 15 tablets. So this is gonna be, we're seeing as a challenge. But what we are intending is we wrote the protocol that Ambroxol can be crushed and mixed with food items and can be actually eaten during the study. So basically, therefore, the ones that has a G-tube can be involved in that. So these are the inclusion exclusion, and honestly, anybody who has Sanfilippo proven with the both molecular enzyme is in this study here. So basically, it is a non-randomized. We originally wrote for 10 patients, but we only have funding for 6 currently. So basically, we're going to evaluate the pharmacokinetics and the pharmacodynamics of Ambroxol using both serum and urine GAGs and the CSF biomarkers, including CSF heparan sulfate. And also there are the neurocognitive assessments, quality of life, and motor function is assessed with a 10-meter walk test and the tug. So basically, I am gonna just move to key endpoints. So basically, what we are looking into here is, in addition to changing GAGs, is change in neurocognitive behavioral scores and QOL scores and the motor function assessments. But obviously, the safety endpoints are the primary outcome of this patient that are including the treatment emergent events and change in physical and neurological exams and the clinical labs. So the future directions obviously include the pediatric patients to be included in the study. We are planning to do a pre-IND meeting when the current, actually the final form of the protocol is approved by the FDA. It's almost there right now. And obviously we are going to be using Ambroxol with other therapies. So for us, any other treatment is okay, including enzyme replacement, so on and so forth, when they're approved. So basically, that is to address the long-term challenge, including having the long high dose Ambroxol. So basically, I thank you for your attention, and I thank again Team Sanfilippo and on their behalf Kathy Buckley to grant this study, and hopefully we'll get further funding to include more patients. Thank you.